start an anti-seizure drug therapy, particularly in adults, one seizure does not mean you go on medicine. Because the risk of having another one can be fairly low in some populations. So it's usual not to start them until they've had at least two, because then the predictability of having another one is fairly high. So not everyone who has a seizure will get treatment right off the bat. So they said some of the clinical variables that increase the risk are having a prior brain insult, so a head injury would be that, a sepsis, a CNS infection, brain infection would also. So these are electroform changes on an EKG, and they've kind of circled them right here. I'm not sure, because I have no idea how to read these, is that this is more of a normal wave in this lead, and these are the more abnormal, is what they're showing you the stopping. But they're showing you some spikes up here. And what I understand is also in adjacent leads you will see similar patterns. So that's what they mean by eleptiform. So in choosing an anti-seizure, well, one's going to be efficacy, that's always, in safety is the next. So potential side effects from drugs. These drugs all have lots of side effects, and again, they have some that are very serious. And many of them can be monitored through serum levels, so that's good, because we know that if they're in what we call a therapeutic range, the likelihood of them getting the benefit that we want and the risk of side effects is very low. You can use serum concentrations to also help you if people are having side effects, is to time when you have those serum levels drawn. Because they may show you that during part of the day, if they continue to have patterns of adverse effects that are happening similar times of the day, look at your serum concentration. So those can help you a lot. You'll notice as we go through here, many of these drugs have extended release. And so what they do is they smooth out the peak and the trough. So usually they'll have side effects with the peaks. They're at higher seizure risk at the troughs. Remember the terms peak and trough? So what those extended release products do is they just smooth that out. The peaks are less and the troughs are higher. The other thing you can do is dose the drugs more frequently, and that sometimes works as well. Keep in mind that these drugs have a high suicide risk with them, but the disease also has a high suicide risk. Folks who have seizures carry a higher mortality. So the disease itself can contribute, but these drugs are also increase that risk. So screening them for depression, and each time screening them for changes in behavior. With children, the adults caring for them would need to know those, what those would look like, and so reporting those would be something you would do at each follow-up visit. Lots of drug interactions. These drugs, especially the older ones, are all metabolized through the P450 system. A lot of them are 3A4 inhibitors, or they're inducers. So like with the two drugs down there, they've listed warfarin and birth control pills. Those are the biggest ones. So always keep an eye out for those. So they chew up estrogen and progestins. So estrogens and progestins are metabolized through the liver. But there is a cycle called the enterohepatic cycle, which the gut bacteria can produce extra estrogens and progestins and recycle it through from gut to liver and back again. These drugs tend to disrupt that cycle. They take out what the liver does, and so the levels of estrogen and progestin fall. So the likelihood of a hormonal product failing is high unless you intervene. So in the past, what I listed there for you is what they're saying also is that we used higher doses of estrogen progestins. So they used to make an estradiol, or an ethinyl estradiol product that had 80 micrograms. Now remember that in the ones nowadays, we have about 20 to 25. So it's a very big difference. But from, you need to use probably at least 50 micrograms of estrogen per pill to overcome that hepatic metabolism. Another option is to use the long-acting implantable progestins is an option. The other is to use 2 forms of birth control. I have seen that. I've seen them use an IUD and a hormonal product, both. Here's the problem. It's double-edged. So the drugs are fairly teratogenic. So you have to have very effective birth control when the woman is using them. The other side is that if they do not have good control, seizure risk during pregnancy carries a high risk of an unviable pregnancy. So it's maintaining, so pregnancies have to be planned. Encourage your women that you see to plan. I'm sure they get that an earful from everybody they see about planning the pregnancy. You'll have to have high-risk folks with you to do that. Questions or comments about that? How old were the kids that you had in your facility?
Oh, from infant state.
Okay, so what'd you do with your teenagers?
Like, when they had seizures?
Did y'all do anything in terms of birth control with them? Really?
Because they live there, so they're just gonna, I don't think so. I never saw that on their med list.
When you're in psych, ask Dr. Britton to tell you about his days at Austin State Hospital, because that was he loved it. It wasn't my favorite place, but he loved it. And he's got stories, so just ask him to tell. Because they would have, the Austin State Hospital was built in a quadrangle. And all of so there was this big open space in the middle, and then all the facilities were around that. So it was enclosed, they could go out, but they were always making out. I mean, they could not keep them from having sex. It was quite a sight, because they would prepare you when you were a student to go on, because it was everywhere. So that's why I'm saying, what did y'all do? Because I think it would be hard to keep them.
They can't move.
They have disabilities.
Yeah.
Oh, I see what you're saying. So you said.
They're on ventilators, so.
Oh, okay. So very disabled
Yes.
kids.
Yes.
All right. All right, so in choosing a medication, page 7, other characteristics, age makes a big difference. So kids, if you remember back when we talked in the beginning, children's liver enzymes, they just continue to increase, or not enzymes, their metabolic capacity really ramps up in their first 9 years. So their ability to chew up some drugs quickly accelerates. So with kids, their clearance is usually higher. They can get rid of the drug faster, so they may need a higher dose per body weight than an adult will. On the other hand, older adults tend to have slower metabolism, so they're going to need a lower dose of the drug. Their renal function, most of these drugs are metabolized by the liver, but some of them are renally eliminated, and some of them have active metabolites that are renally eliminated. And they have decreased volumes of distribution. They get smaller, and their water volume goes down compared to their body surface area. So keep those in mind. About age makes a difference. Women on combination contraceptives, we talked about. Pregnant women, on page 19, I've taken what I gave you in pregnancy with regards to some of the drugs that cause neural tube defect, and the dosing of folic acid starting ahead of time before pregnancy or conception occurs, and keeping them high doses those first trimester. The other 2 things to keep in mind is that the woman should take through pregnancy the drug that controls them the best, so we don't switch them off. Some women will wait until they have been seizure-free for a number of years, and then they will come off the drug. They can be tapered down and can try to conceive then. So all that needs to be done with a specialist helping them. Switching medicines during pregnancy is not recommended. If you think back to the teratogenic lecture when we were in the OBGYN module, is that if we have to expose the fetus to a drug, we'd rather only expose them to as few drugs as we have to. So that's what they're getting at there, is that you don't want to expose them to 2 different drugs, if at all possible. Patients with hepatic or renal insufficiency, so there's a few drugs, you do not have to know these specific, but remember the concept that some drugs that are renally eliminated will have to be adjusted in renal insufficiency, but they may be more useful in people who have hepatic insufficiency. So that's what they're trying to say in those first 2 bullets. The very last bullet, among all the anticonvulsants, this is an important one to remember, is phenytoin, carbamazepine, valproic acid, and felbamate have a high risk or have a significant risk of acute liver toxicity or liver injury. So keep those in mind. HIV is also a risk. One is that the number of drug interactions is huge. The other is that we don't want to interfere with the metabolism of their HIV regimen because that puts them at risk. So most of that comes in the pharmacokinetic realm. Their ability to adhere to a regimen, so the less complexity, the better, and insurance coverage. A lot of the older drugs are very cheap, but there's a whole list of new ones. If you look, I think it's the next page. Yeah, there's 21 drugs. I would say the majority of them are going to be second line because the old drugs are still very good and are still used. Of the top ones, valproic acid is probably the number 1, and then topiramate and lamotrigine, which I don't know if it's generic or not. But a lot of the rest of them are going to be brand. I'd say at least half of them. So that may be where the problem comes from a cost standpoint. Patient education, huge, on why they need to take their drug, how they need to take it. Some of them, it's very important that they take it at the same time, they don't switch formulations. And medication adherence is your number 1 reason for failure. So talking to them about and assessing adherence each time you see them is important. Questions about those? Those are just general principles. Some similar to other diseases we've talked about. Maximize the likelihood of success. We start with 1 drug. The majority of people can be controlled with 1 drug. We would like to keep people on 1 drug. There is not that much that is gained with adding a second drug. So you may be able to get 70 to 80% seizure-free. Adding another drug will not get you to 100% seizure-free. Drugs are often added in refractory cases. So it's possible, but it's more unlikely to see 2 drug therapies. In terms of titration, start low and advance slowly. Some of it's because of the side effects that occur. The others is because the variability in patients achieving a therapeutic range are very wide. So it's not predictable exactly what dose will put them into the therapeutic range. Monitor regularly. So a lot of these drugs will have serum levels that will be drawn. And that's good. That's a good thing because that gives you something to shoot for. Regular follow-ups are really important, so stressing that. So that you may be seeing them more on the family medicine or primary care side unless you're specializing in neurology. But the neurologist may not see them that frequently if they are stable. So that it may fall to you to do some of that monitoring. Or you may need to monitor when side effects pop up that you're not sure, or if the patient's has gone rogue with their treatment regimen, and you need to find out where they are. A couple of these we talked about. Questions about those? Okay, let's talk about the drug classification. So we have drugs that will treat both focal and generalized, and we have some drugs that will just treat focal. So that's pretty easy. You do not have to memorize this, I'm just giving you a reference table. And you'll find that some of these actually are in both categories, like carbamazepine is used for generalized and focal as well. The thing that will drive you nuts with seizure medications is that there is no algorithm out there as to where to start or what to go to next. A lot of it's going to come from your specialist. With kids, there's a little bit better in terms of where do you start, what do you do next. But in adults, it's really you start one place and you see how they do. So that makes it more difficult. But I will go over the ones that are considered first line, and then some of them that are N2 for refractory. And the vast majority of them I'm not going to cover because I think unless you are in a specialty group, you're not going to see them very often. So I've covered the ones that I think you'll see the most, and also the ones that will cause the most trouble for patients. Okay, so let's start with valproic acid on page 11. So divalproex or valproic acid, interchangeable terms. Defecaine, Depakote are the trade names. It would be important to document because there is a difference in bioavailability and how you dose drugs based on the formulation that you choose. So if you look under products, you have valproic acid capsules, which is Defecaine. Rapid absorption, peaks in 1 to 3 hours. If you're dealing with that drug a lot, and you'll see it quite often, then knowing when that peak occurs is helpful because that's when side effects are most likely to occur. There is a syrup for kids or for people who have trouble swallowing a tablet or a capsule. And then there's the delayed release. You'll see a lot of this. The Depakote DR and the Depakote ER is probably the most common of the two, the extended release. So if you look at the Tmax on it, it's 7 to 14 hours. It's very long. But it does tend to smooth out the peaks and valleys that you get with using a regular release. The kinetics on these drugs are going to be important for you to look at. So I tried to write at least the objectives to call your attention to that. So these are extensively bound to albumin. So that's where most of our drugs are going to bind, are going to be albumin, all drugs. And it's the predominant protein in the blood. The binding is saturable. So what does that mean? So if you have an albumin molecule and you have so many sites, once you fill them up, you have saturated all the binding sites on that drug. So what is bound and what is free are in equilibrium, right? That's in the blood, and then that is in equilibrium with what gets into the cell. Okay. So once you bind those sites, or you throw in a drug that competes, let's say we throw in a different drug, and now it kicks this one off, and it sits there. Kicks this one off, and it sits there. So your free goes up. If your free, unbound drug goes up, then the amount that conserve a physiologic effect goes up. Okay. So most of the time when we're dealing with drugs, we have a great capacity of albumin to bind it. But in this situation, we don't. So that's an important one when you're adding or taking away a drug that interferes or competes with them for binding sites on albumin. Then your free amount goes up, and so toxicity can go up. So that means that sometimes you have to look up at what's the protein binding of this drug. Most of the time, high protein bound, there's no one definition, but usually when you're getting into the 98 to 99% range, I would start looking when I get above 90% of the other drug being protein bound. But these are usually, when you're talking about highly protein-bound drugs, that's where they're usually talking about. Okay. So that third bullet, highly protein-bound drugs can displace valproic acid. It's metabolized through the P450 system, so those 3A4, I don't know if that's a 2C9, I have to look. It does cross the placenta. The kid gets higher levels than the mom does. Under number 5, this one is really important because when you switch from Depakote to Depakote ER, the dose should be increased by 14 to 20%. So if you go from regular release to extended release, so let's look how that would look. So regular release comes, I think, in 250s and 500s. So, and the usual starting dose is 10 to 15 milligrams per kilo, but let's usually somewhere in the range of 750. So if we've got them on 250, let's say 3 times a day, and we're going to take them to an extended release, how much more are we going to have to give them? Get your calculators out. 150, okay. So you're going to have to add 150 milligrams. So you're going to give them 900. That would be at the upper end. Okay. So the other would be to 75, so about 100, 125. I'd probably go more in the middle till I knew what it did. Okay? Got that? I'm sure it will ask you that. So it's really important to not forget that. Okay. Side effects. So GI are most common. So there is an enteric-coated form. So enteric-coated are usually going to keep the drug from dissolving in the stomach, move it to the small intestines. So you could use that. Thrombocytopenia, more of a problem in kids than adults. So we don't routinely in adults look at their platelets. Chronic is weight gain, and it can be significant. So warn your patients or work with them on how to decrease that if that is a risk for them. Hair loss occurs. It's temporary, usually will grow back in, but warn them so that when the clumps of hair fall out in the shower, they're not too weirded out about it. Ammonia goes up. It doesn't mean their liver is damaged. I don't know that there's anything you do. It just is a kind of a phenomenon. The next page, this one's really important, the liver toxicity. It's the most serious of the adverse effects of valproic acid. More common in kids, in little kids under 2. If you look at the risk factors, it's children under 2, those who have mentally retarded, inborn errors of metabolism, they use multiple anticonvulsants, or they have very difficult to control seizures. Know those risk factors. Usually occurs early in treatment. I think that it will be hard the child isn't going to complain of these, but they can be observed behaviors. The nausea, vomiting, and lethargy, not eating. I don't think the kids get to do that. It's probably more in adults. So for the first year, you're going to monitor their liver enzymes. Questions about that? So the advantage to valproic acid is it's very effective. It comes in a wide variety of dosage forms, so it's easy to adjust and to meet a lot of patients' needs. The downside is that its side effects are significant, common, and it's an enzyme inhibitor, so it interferes and interacts with a lot of drugs, and it has multiple drug interactions. Questions about valproic acid? All right. Okay, let's go to lamotrigine or Lamictal. So it is, it can be used as an adjunct, it can be used as a primary, so it could be added to therapy, or it can be used as for primary in absence and in generalized seizures. Products. It also comes in a lot of different dosage forms. So regular release, it has a chewable dispersing tablet, orally disintegrating tablet, extended release. So its kinetics are an advantage. So if you look there, it's complete. It's got good bioavailability. To get to 98% is really good. It's not affected by food, so that gives you flexibility. Clearance is higher in children, lower in adults, like we talked about. It doesn't inhibit liver enzymes, so it doesn't tend to have as many drug interactions. The problem is that the drug interactions it does have can cause some significant side effects. It's often used, or it can be used in combination with valproic acid, and that can lead to some bad happenings. Let's see. So valproic acid can substantially inhibit the metabolism of lamotrigine. This occurs when you've got doses of 500 milligrams a day or serum concentrations in the 40 to 50, which is fairly common. And it also interacts with carbamazepine. Those are two very commonly used anticonvulsants. So this is important. Look at the dosing because it depends on how you're adding the drugs or if you're adding it to something or something's being added to. So maintenance dose, if you're using with valproic acid, then dose escalation rate and rash incidence makes managing the dose very critical. Okay, so a very bad rash can occur, Stevens-Johnson syndrome can occur when using valproic acid and Lamictal together. If you take valproic acid away, then the dose of lamotrigine will need to go up. So where you have to start is that it's valproic acid inhibits the metabolism of lamotrigine. So you move it away, then you'll have to take more dose. Make sense? Think that through because I can guarantee you all have questions on the test that will make you think through adding a drug, taking a drug away. And your objectives, I've tried to make sure that those are all pointed out. If the enzyme inducer is removed, then lamotrigine dose may need to decrease. So you have to start with how's the drug metabolized, and then when a significant drug is added, what happens to the clearance or metabolism of the drug. Okay. Headaches are most common, but the side effects due to drug interactions are the most significant. So let's walk through those. So if it's used with carbamazepine, then vision changes, diplopia can occur. Tremor with valproic acid. The rash is the real problem. It can occur early in treatment, within 3 to 4 weeks. The rash that they get is a morbilliform rash, so it would look something like this. So it's usually generalized all over the trunk, can be erythematous, more angry looking than this, and more morbilliform. Now, the other bad thing that can happen is Stevens-Johnson's. This is one of the better pictures I could find. Some of them are so distressing. So this is an allergic reaction that can occur. It's one of the most severe. It can be fatal. So we want to monitor for it and also do our best to prevent it. So the risk factors are listed there. Serious rash include the concomitant use with valproic acid, and where initial higher doses or a rapid dose escalation occurs. Incidence is higher in kids than in adults. You can Google it if you want, but I'll tell you it's distressing to look at them. So keep that interaction in mind. It's a very important one to remember. So if you go to the next page on top of 13, so the advantages of this drug of Lamictal is that it's very broad spectrum. It has a lot of use. It's probably one of the top 3 that are used for treatment of seizures. It has multiple dosage forms, so it's very flexible in meeting a patient's need. It has linear kinetics. So what's that mean? Okay, so this is drug concentration over time. So, whoops, should say dose. Sorry, dose. So that's what linear looks like. Same?
Yeah.
Yes, it is. So linear means that the change in dose causes a proportional change in the response, or the amount of drug in the blood. So whether I go from a dose of 100 to 200, or I go, let's say, 300 to 400, the change in drug concentration is proportional. Okay? That's linear. We'll get to nonlinear when we get to phenytoin. It's not highly protein bound. Good. Doesn't induce or inhibit the metabolism of other drugs, but they inhibit its metabolism. So topiramate, we talked about it yesterday. Again, it's another first-line drug, so it's one of the top 3 that are used. Can be used as an adjunct, can be used as monotherapy, so it can be used combination or by itself. It's approved for tonic-clonic, so it's approved for generalized seizures. If you look under kinetics, it's renally eliminated. That's good, because that may come in handy. You have to titrate it slowly to avoid adverse effects, and it has linear kinetics for the most part. Usually when they're saying that for the most part, what they mean is at the lower dosing end, and usually even as you get into the higher end, it maintains linear. Now when you get above, you might see it start going like that, but in this range, it tends to behave this way. So the side effects, like Sony told you yesterday, it's the word finding, short-term memory loss, impaired ability to think. Also remember the stones, renal stones, kidney stones are common, so making sure patients stay hydrated. Anorexia and weight loss. Sony gave you that example yesterday of not being hungry, so anorexia. The paresthesias in the fingers. She gave you almost all the big ones. She had them all. Fatigue and taste perversions also go along with that. So advantages are that it's very effective across a wide range of seizures. It's renally eliminated. That's good. And it's linear kinetics, and it's very few drug interactions. The downside is its effects on cognition and thinking. Questions about those? So those are the top big 3. So we're going to talk about 2 adjuncts. So these are usually added to. Sometimes you will see them used as monotherapy by themselves, but they're often added to their broad spectrum. Probably the one that is used the most is Keppra. So I always have to think about how to say it. Levetiracetam. I just say Keppra. So again, against a wide variety of seizures. Has a lot of different products. It does come IV. It's renally eliminated. Good. Clearance is higher in kids than adults. So its side effects that are common are the agitation, irritability, and sleepiness, fatigue, somnolence, sleeping too much. To minimize the effects, we start at half the dose and titrate up. So the advantages here, again, linear kinetics, like that on the board. It's metabolized by it's not metabolized by the P450 system, so its ability for drug interactions is low. And it's fairly well tolerated. The other one is a newer adjunct, perampanel or Fycopa is an adjunct. With it, if you go down to the third list, this is more in resistant seizures. It can cause an additional 50% reduction in refractory focal epilepsy, so focal seizures, whereas Keppra is for general. It is metabolized by the liver and it hits all the big ones. Its most common side effects are similar. They're CNS, so the dizziness, the sleepiness, headache, irritability. I do want you to draw attention to the last part, the box warning, is it has serious neuropsychiatric effects, including alterations of mood and aggression. So keep that one in mind. You have a objective written over it. Okay, questions about those? All right, let's go to page 15 now. These next ones, Tegretol and phenytoin, these are drugs that have been around forever. Phenytoin is probably 100 years old. It's been used a long time. Tegretol is probably 50 years old. So these drugs have been around a while, but they have problems with them that make them more difficult to dose. They're certainly effective, but the side effects are problematic. They have some kinetic variations that make them difficult, and carbamazepine has some wicked side effects. So let's talk about it. So Tegretol, broad use, can be used in a variety of focal and generalized. Lots of products. If you look down at the bottom, it has an immediate release, slow absorption, erratic, large variation. So people don't use it as much. There's a suspension for people who can't tolerate it or kids. Controlled release tablet, that's probably more commonly used, the XR. The outer casing, so it's in a matrix, and the drug, as it goes through the GI tract, absorbs out of that matrix. So you have to warn patients that, and this is not, I couldn't find a picture of it in the stool, but I did find one of desvenlafaxine's, very similar. So they'll excrete this shell-like, and so they may tell you, I'm not absorbing, or that tablet shows up in my poop. So warn them that that's normal, and that they did absorb the drug, and you can tell by monitoring their blood levels. Again, like I've always told you, never, ever crush an extended release or product because you'll ruin the kinetics of the drug. So one thing to look at are bioequivalents, or if drugs are interchangeable when they are different extended or sustained release. So this one comes up quite often. So the controlled release, the Tegretol XR, and the sustained release product Carbitrol are bioequivalent and they can be interchanged. Often we don't do that. We don't exchange one extended release product for another, but in this case it works. Both of them lower the peaks and raise the troughs, so they smooth out the serum concentrations. Okay, top of next page. Metabolized by the liver. It has an active metabolite, which you have to keep in mind, because the active metabolite, just to make things more difficult, is the active metabolite can also have drug interactions and problems. So when you're giving carbamazepine, you're actually giving two drugs, so that you have to worry about. The other phenomenon with carbamazepine that is different is it auto-induces its own metabolism. So that is mostly a problem in the first month that you give it. So we start at a low dose and we keep gradually increasing that dose over the month. Because the more drug you give, the more it auto-induces its own metabolism. You don't see that in very many drugs, but this one, it's a problem because if you don't recognize it, then the person will fail. You won't get therapeutic effect. So you have to keep increasing that dose over the 4 weeks. And then autoinduction will become stabilized, and as long as the patient's taking their drug and nothing else big happens to them, then you can have stable response. The half-life of the drug declines with chronic therapy, so it's just one of those oddballs. Kinetics people love it, it's interesting. It's just a pain in the butt for practitioners as you're trying to get everything stable. There is the therapeutic range. You don't have to know that, but you should be aware that it does come under therapeutic drug monitoring. So that's kind of an abbreviation, therapeutic drug monitoring, TDM. Means you've got a serum concentration that is related to therapeutic outcome. Okay, so under adverse effects, has a lot of them. Hyponatremia is one of them. It is a drug that will have ADH-like activity. It enhances the activity of ADH in the collecting tubules, so you can have an nephrogenic effect. It is one of the causes, if you have somebody who comes in with SIADH, this would be a drug to think about in terms of drug-induced SIADH, and there are quite a few of them. So the elderly who are already on natriuretic drugs, which would be what? What would fall into that category? Natriuretics. So they affect what? Sodium. Okay, so what drugs do we give that affect sodium? Thiazides. So your diuretics. So if they're on a diuretic, which a lot of them will be, then they're at risk. Leukopenia is common. It's usually mild, usually reversible. It's thought to be due to a redistribution of white blood cells in the body. You can continue and treat through it unless you meet that criteria at the bottom. So unless the white blood cell count drops below 2,500 and the absolute neutrophil count drops below 1,000, you don't have to stop the drug. Be sure you know those endpoints. It can cause a very bad agranulocytosis and aplastic anemia. So you need to monitor CBC. You need to have a baseline and have periodic monitoring with this drug. It also will cause a morbilliform rash, like we saw with Lamictal. It also can cause Stevens-Johnson syndrome, but there is a way to monitor for who is most likely to get it. Number one, if you see a patient of Asian descent, it is recommended now that you do a screening, and it's listed there for you. So looking for that HLA antigen 1502. If they have that, if it's positive, don't give them the drug. Now, there's another HLA antigen, it's on the next page. It's 3101. It is more spread out in the population, so you can find it in almost any ethnic group. So there are recommendations now that any time you put somebody on carbamazepine, you should screen them, but that is not widespread. The only one where it's a strong recommendation is for those of Asian descent. So advantages and disadvantages. It doesn't have as much neurotoxicity as the other agents we've talked about, but it does have a lot more blood dyscrasias. The disadvantage is that you've got this active metabolite that is also you've got to think about, but on the other hand, you have an active metabolite that also exerts therapeutic effect. Autoinduction will make it more difficult, particularly if you don't remember or don't pay attention to that. If a patient stops therapy for a period of time and restarts, that autoinduction starts all over again. It may not be as significant, but it will be part of it. It's very teratogenic, so this is the one where it will cause neural tube defects, so you'll have to put the woman on a folic acid high dose. Questions about carbamazepine?
I have a question.
Yeah.
On some of the other drugs that cause Stevens-Johnson syndrome, should you also screen?
As
Just
far as
that
I
one?
know, there's no screening for it. And why this one in particular, I don't know. But it's out there and it's a test that's available. Good question. The last one that is very common is phenytoin. It's the one I told you has been around about 100 years. Very effective, but it has lots of quirks. I love it from a kinetic standpoint, but it really is a more difficult drug to use. Very wide action in focal, generalized, has an IV. We can use it in status epilepticus. Very good. The problem we get into, it has 4 dosage forms. If you look under mechanism of action, there's 4 forms. There's a prompt release capsule. That's probably one of the most common. There's an extended release capsule. Those are both sodium salts. The suspension is not of sodium salt. It's straight phenytoin. And there's a chewable tablet that's called Infitabs that I believe is not a salt. So the problem is that that in those that have 100, like the Infitabs, when you give an Infitab, it's 50 milligrams of phenytoin. If you were going to give it an equivalent in the capsule, it's only 92% of that, so about 47. So you're going, why does that make a difference? Because this drug follows Michaelis-Menten kinetics, nonlinear kinetics. If you don't remember anything about phenytoin, remember that, and it'll keep you out of trouble. So with this drug, when you look at on the next page, here's what you get. So if I'm dosing from here to here, I get that change in concentration. If I dose from here to here, I get that change in concentration. Okay? So it is not linear. So the higher the dose, the more response you will get in terms of a drug concentration. So you can't go from, if you go from 100 to 200, you'll get one response. If you go from 200 to 400 or 300, you will get an exaggerated response. I can tell you all the time, this is where I'll see people get in trouble. They'll either write for a different dosage form, and then you're dealing with more drug, and so they get an exaggerated response. This is a drug that has a very narrow therapeutic index. It's 10 to 20. As you get above 20, the side effects go up. So the side effects usually are gait disturbances. To watch somebody who has phenytoin toxicity is like watching somebody in a at the fair, those weird houses that you can walk through. The mirror house, that's what they look like. And the other is they have nystagmus on lateral gaze. So that's another common when you go to about 20. The other is that the further out you are, the more you're on here, the longer it may take to see it show up. So from here to here, you may, a small change at the lower end, you may see the effect on their serum concentration fairly quickly. When you go from here to here, instead of hours, it may be days or weeks. So a lot of patients, when I was a resident, that's what would happen. Somebody would take an old patient and increase the dose by very small amounts, and you get huge change in their response. Here's another problem that happens. This I found more in the hospital when I was resident. Phenytoin is a suspension. So what do you know about suspensions? You got to shake them up, and the longer they sit, what happens?
Separate?
So if you don't shake them up, where's most of the drug?
Bottom.
Follows gravity. Well, they would send up phenytoin suspension because the patient couldn't take a tablet. Nurses wouldn't necessarily know to shake it up, or they wouldn't shake it up each time. So if you've got a new bottle, what are you taking? Taking that concentration. So it comes as a 125 per 5. But as you get further down the bottle, now you're taking this. Okay? It's a problem with this drug just because of that Michaelis-Menten. Interesting kinetically, but difficult to dose from a patient and a provider standpoint. I would, if my advice to you is pull in a kineticist, most of the pharmacists in a hospital will have that kind of training. Or ask for people who can help if you can't make the adjustment. The biggest thing is if you make adjustments, make very small. Like if you're out more in the mid-range, make very small adjustments and then follow it up quickly, and also know that you need to follow it up long-term because it will take longer to get to steady state. Okay, just two more things and then we'll stop there. You see that picture? It's not in color for you all, but gingival hypoplasia is terrible with this drug. This is exactly what it looks like. So getting a dentist involved, they can help you with that. Very common in kids and with adults that are on it long term. It also decreases folic acid. Where did I write that? Okay, what it does. I think it decreases folic acid absorption, but if you replace the folic acid, it will reduce your phenytoin concentrations. So you have to make small adjustments if they're going to be on it long term. The advantages are it's been around a long time, so you know how it works, but it does take some care and some oversight when you are using it. The next page is exactly what I gave you in pregnancy. I took the page and just copied it back over. So look through that again, remind yourself if you've got patients who are on the drugs. And here mostly I'm looking at the ones that are related to anticonvulsants, not the women who are at risk for neural tube defect because of their history. I'll stop there. I'm going to wait and see. I'll talk to Dr. McNeil about doing status next week. I think your person who's coming in is going to cover that as well. So I'll either just tag it on to movement disorders or I may ask him for a short bit of time. Questions?